It's just a pleasure to be able to join today and help to kick off the speaker series for 2023. I want to begin by acknowledging that I'm joining today from the unceded ancestral territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. And as an uninvited settler, I'm grateful to be joining you from these lands today. I have no conflicts of interest or disclosures to declare regarding my presentation, but I would like to acknowledge the many different partners and organizations that are involved in supporting this work and contributing to it, either as members of the research team or funders and folks who provide infrastructure. So today, I get to talk to you about abortion access in Canada. So we'll begin by looking at the landscape and the history of abortion access and changes that really facilitated an increase in access. And then I'm going to summarize the experiences of healthcare professionals who are new to abortion access since the 2017 implementation of the abortion pill in Canada. I'm going to focus in on a community of practice and talk about the different supports that our research team was able to develop to enhance and spread abortion access in Canada. And then I'm also going to talk a little bit about a survey that delved into experiences of stigma and harassment. And I'm doing that because I think that the more that I share the results of this research, the more I hear from other researchers and clinician scientists about their own experiences of stigma related to sexual and reproductive health services, not just from patients and people seeking care, but also from the practitioners who provide those services. So I think that there's some important learnings and discussion we can have around that shared theme in our work. Finally, I'll talk about some future work that we've just got underway. So the context of abortion access in Canada. For everyone's context, I know there's many experts here on the call, but for those who aren't familiar, before 2017, access to abortion in Canada was quite limited. A health human resource survey conducted by my colleagues and led by Dr. Wendy Norman was conducted in 2012 that identified only 94 facilities that provided abortion access in Canada, half of which were in Quebec, and the vast majority within 100 kilometers of the US border. Only 270 abortion providers practiced in Canada. And for reference, there are a little over 2,000 obstetrician gynecologists in Canada and 43,000 family physicians. So the proportion that were abortion providers is quite small. At the time of that survey in 2012, 96% of abortions were performed surgically, and the remainder by off-label use of methotrexate and misoprostol. This all meant that the majority of people seeking an abortion had to travel significant distances for care, which takes time, and that requires out-of-pocket costs. Traveling to access a surgical abortion can also be really difficult to keep confidential from a partner or family member. However, in 2017, the medical abortion pill had the potential to increase access to abortion in Canada. This is the gold standard for first trimester medical abortion care. It had been available in other nations for over 30 years, and it took a long time for Canada to receive a drug submission because of a combination of factors. But we did receive a submission. It was approved in 2015. It was made available in 2017. Some important context here. Canada has no legal restrictions on abortion care, and the right to abortion access is enshrined in the Canada Health Act. But unfortunately, the company distributing mifepristone modeled its submission after Australia's distribution system, where abortion is much more restricted. So my colleagues and I, led by Dr. Wendy Norman, hypothesized that these restrictive measures in Health Canada's approval would hinder implementation. And I've listed the initial restrictions here for you to look through. So for instance, initially, only physicians were permitted to prescribe, not nurse practitioners as well, for whom prescribing is typically in scope. Pharmacists were not allowed to stock and dispense the drug, only physicians. And that's not how medications are dispensed in Canada, and it's actually prohibited by regulators in Quebec. So we recognized we had a clear policy window. I participated in writing a series of grants for a study together with the leadership of Dr. Wendy Norman in the Department of Family Practice at UBC. as well as with a network of clinician scientists from across Canada. Our team planned to partner with Health Canada at all stages of this project. We wanted to provide them with evidence on what factors influenced the implementation of the abortion pill in routine care. In order to get access to Health Canada and become a trusted knowledge partner, the project team included clinicians and regulators that Health Canada was already consulting about the drug submission. Although I joined the team in 2016, the collaborations that guided this project had been in the works for 10 or more years. And so I'd like to provide you an overview of the objectives of the study and then focus in on the qualitative component that I led. The goal of our research was twofold. First, to understand and investigate the factors that influenced the implementation of the abortion pill in Canada, but also we had a knowledge translation goal to partner with decision makers to address barriers, implement facilitators, and improve access to medical abortion with mifepristone. So this was very action-oriented, highly partnered research. It was a mixed methods national implementation science investigation. On the left here, you can see it included surveys with prescribers and pharmacists. And on the right, we had a component of interviews that I led with a subsample of those survey respondents, as well as decision makers who were involved in implementation. The project was formed by an integrated knowledge translation approach, which is there at the center. IKT is a process of partnering with people at all stages of the research process who will be in best position to use research evidence to inform impact. It involves sharing knowledge and expertise. It involves ensuring that the evidence is co-produced so that it can be useful and relevant, and then hopefully has a higher likelihood of being mobilized in practice and policy. So I engaged in monthly feedback sessions on behalf of the team. These were led by Dr. Wendy Norman, and we exchanged results in progress to see how implementation unfolded. And we were also really interested to provide supports to providers who were new to abortion practice. So you see here at the bottom, the National Community of Practice for Abortion Providers, called CAPS. This was one of our team's KT interventions. It was an incredible resource for pushing information out to the health professional community, especially when there were practice updates, but it was also a space for information pull. It meant that I could conduct rapid data collection with early adopters of medical abortion practice, and then share that as part of our results and evidence in progress with key decision makers. So to date, our research team has published over 12 manuscripts from the project, and I'd like to focus in on two key papers here. These present results from the interviews that I led with 124 English-speaking prescribers, pharmacists, and decision makers. I used a purposeful sampling framework to ensure that the participants included those with a range of abortion experience, from early adopters to those who did not yet provide mifepristone. I also sought to have a range of demographic characteristics in the sample, knowing that practice patterns can vary by the age of the provider, the region that they practice in, and gender, among other factors. I also conducted repeat interviews with a subsample to see what was changing over time in their practice. And in total, we had over 150 hours of audio recorded interviews, a huge amount of data that required a full team effort to conduct the data analysis. And throughout the work that informed these papers, as well as the surveys that were conducted alongside them, our team had monthly video conference meetings with Health Canada. We were so delighted that Dr. Supriya Sharma, Chief Medical Officer for Health Canada, joined in many of those meetings or invited a member of her team. We prepared slide decks that showed our data in progress from the surveys and the interviews, as well as the community of practice. And we provided updates on provincial policy changes, which we learned through our connections with regulatory bodies. We often would create policy briefs that synthesized the evidence when there was a clear consensus from the data sources. And I'm going to give you a sense now of what that data looked like. And so this is, I'm reporting primarily here on the qualitative results, but want to show you how the survey data fit in with that. So first, here is the very summarized table 1 characteristics of our survey sample. So the denominator of that final sample was 453 respondents. In the final survey, you see here that the providers were primarily physicians who practiced in primary care settings. 46% had never provided abortion services before. And these survey respondents provided really critical descriptive data on the characteristics of providers, where they were providing, the factors that influence practice. Through our mixed methods approach, this was helpful for me to then identify questions to pursue in the interviews. And then in the interviews, I was able to capture more context about how the restrictions were impacting practice on the ground. And then I could compare it back to the survey data and bring that to Health Canada. So I'll start here with one of the overarching themes that we learned in the first 6 months, primarily that Health Canada made mifepristone's implementation more complicated than it needed to be. Family physicians who can prescribe this in rural communities all over Canada shared with us that they definitely would not have prescribed Miffy had Health Canada stuck to the original rules where physicians had to stock and purchase and store all the products at their own clinics. Prescribers also confirmed that the initial restriction to watch the patient observing their medication was paternalistic and not evidence-based. As this participant noted, I can't think of a safety reason that's more significant for that medication than it is for tons of others that are prescribed or taken at a pharmacy. At a clinical practice level, we also noted key differences in how rural and urban prescribers were setting up practice. Non-adopters, so those who weren't providing mifepristone, but perhaps were in a good position to, they were primarily in urban communities. In contrast, rural participants were used to adopting new practices to expand access to health services in their communities. They had limited health human resources in their communities and less desire to send their patients away to referral centers. And they were more easy, it was a little easier for them to adopt this into their general practice. Urban participants, in contrast, were more comfortable with referral patterns. They frequently assumed that there was good access in their community, and they preferred to send patients to abortion who are seeking abortion to a specialized abortion center. This, however, as you can imagine, it creates an extra step in the patient's pathway. This can compromise safety and confidentiality. It can extend the length of an unwanted pregnancy. So identifying and mapping these differences in practice was critical to engage in strategic KT with physician organizations. I also identified that pharmacists largely experienced a smooth implementation process, but for different reasons. Whereas rural prescribers benefited from having the autonomy and readiness to adopt new practices, pharmacists were largely employees, and they depended on vertical communication from their pharmacy or their college. One key thing for dispensers was getting communication early and consistently. So one pharmacist told us, for instance, that the moment they received an email from their professional organization, it made them feel that eventually all pharmacists would be dispensing mifepristone, and all pharmacists are obliged to at least be knowledgeable about the product to help people in case they needed the prescriptions. So these data with prescribers and pharmacists helped me to identify which groups to collaborate with. And this was especially important as restrictive measures were being rolled back. This next slide, I really love to share it because it really shows the impact of what happened. Essentially, within 11 months after mifepristone went on the market, Health Canada had removed all restrictive measures. We are the first and only nation in the world to offer abortion care as a publicly funded health service with no legal restrictions that can be prescribed in primary care and dispensed from a pharmacy. We are an example that other nations are looking to when considering how to make abortion care more accessible. And I am delighted to have been a part of a research team where the evidence contributed to this massive shift in access in Canada. I want to share a little bit more about some of the restrictive measures and kind of go in depth into how the integrated KT contributed to this massive change. And so if you recall earlier, I presented this slide, which outlines the restrictive measures that accompanied mifepristone at the time of its approval. One in particular was that prescribers must register with the drug manufacturer, which includes sharing their name and their contact information. If you can imagine, this is a level of disclosure that most prescribers would be uncomfortable with for anything in general, but something in particular like abortion care is quite sensitive. So I want to use this as an example to show you the steps that we engaged in, from identifying a knowledge gap to Health Canada removing the specific restriction. Early in the study, here if you see at the start of the map at the top left hand of the journey, early on in the study, we observed survey data highlighting the specific barrier about sharing personal information. One of the RAs with our project, Courtney Devane, was noticing patterns of concern from our English-speaking participants. They were worried about sharing their personal information, and we had heard about this anecdotally as well through clinician scientists on the team. So we checked in with our Quebec co-investigators. They were seeing the same patterns in their French language data. Then we looked at the interview data to see in what context this was a barrier, and it was persistent across interviews. So we emailed our synthesis of data in progress to Health Canada ahead of our monthly meeting, and they asked for more data since these were preliminary. So we conducted a rapid poll with members of our Community of Practice website. We then prepared a more detailed evidence brief, which included, I believe, some international data, if I call it correctly, and through discussions between Wendy Norman and Health Canada and other partners, Health Canada removed this restriction. They sent an update to prescribers and stated quite clearly that physicians' personal information would not be shared with the manufacturer. This process, this map here, happened over the span of 4 weeks, just as Health Canada started coming regularly to monthly meetings. This integrated KT alongside the research process solidified the value of our partnership and built trust. And it's something that we've tried to emulate throughout our research studies since then. And so to summarize what we learned through the CART-mifepristone implementation study, Health Canada's deregulation of the pill was a global first. It led to improved access to abortion in rural settings and among primary care providers. These changes also allowed Canada to transition to no-touch medical abortion protocols during COVID-19, which was unanticipated, but an incredible and positive outcome. And Health Canada and partners continue to collaborate with CART and our team in anticipation of future policy windows for family planning. This includes scaling up and sustaining supports for practitioners and identifying ways to help patients access abortion quickly and closer to home. One of the things that's ongoing as an output of this project is our National Community of Practice for Abortion Providers. This again is a key KT intervention. We were able to see our interview and survey data that the community of practice was a key way that practitioners and dispensers were able to get information about the regulatory changes. It was a space for information pull. I could also construct rapid data collection with early adopters of medication abortion practice. We could use that mailing list to send rapid polls to abortion providers. We could see if the changes to restrictions were having an immediate impact or not. One of the things, though, that we were interested to do is understand what the community of practice meant from the perspective of those who were participants in that practice. And so I'm going to turn to an evaluation that was led by my colleague, Dr. Sheila Dunn. And with our team, we presented these slides back in 2021 to Dr. Sharma and Health Canada. We published our results in JMIR. And again, I think that it's interesting as a case example for a type of strategy that can support healthcare providers, not just to adopt a new practice, but specifically a practice that is associated with stigma. This here is the screenshot of the CAPS Community of Practice platform. The main page has an open access repository of resources that can support people who are providing medication abortion. And then you can log in into the password protected confidential portal to access additional resources. You can see here the link at the bottom of the page, and I'm going to share it on the final slide of this presentation as well for anyone who's interested to access it. We launched the website right after mifepristone was made available in 2017. And we had this slide here that you see on the right at the end of the initial mandatory training program that all prescribers and pharmacists had to complete. We invited them after completing that training to join the community of practice. The clinicians who were part of our team also engaged in a bit of a roadshow. They promoted the new practice guidelines around medical abortion and the CAPS website at a variety of conferences. And importantly, as you can see here from the logos at the bottom of this slide, it was endorsed by all national professional organizations relevant to provision of medical abortion. This added to the sense of trust in the content of the website and who was hosting it. It was completely disconnected from any drug or manufacturer. And we also really wanted to emphasize that it was an evidence-based resource that was consistent with best practice guidelines. So the virtual community of practice, as I've mentioned, it enabled us to collect information real time, but also to share information to address what we were beginning to learn about barriers and facilitators. I'll point out here that we constructed it in a really systematic and evidence-based way based on what we knew worked to address different knowledge translation gaps. So for instance, around what we knew was a barrier, setting up a new practice, it requires gaining clinical knowledge. So the website included easy access to clinical practice guidelines, systematic reviews. It had frequently asked questions and answers as well that helped to translate some of those key learnings from the guidelines into material that could be easily absorbed and adopted into practice. We pushed out member announcements by email after learning quite quickly that it was hard for people to take the time to sign in to a password protected portal. And so sending out these push communications by email was a great way to continue to engage the community and also feed back to them what we were learning so that they could continuously improve their practice. I also want to point out here this more behavioral barrier that we identified early on, that abortion providers often feel isolated in their practice. And so we wanted the community to have resources that could support them to build connections. In particular, we wanted to make this available for family physicians and other primary care providers who are offering this as a new part of their general scope of practice so that they could connect with experienced abortion providers who could advise them on difficult cases. So we had an Ask an Expert option, for instance, that was really used quite a bit in the first year of CAPS availability. Here's an example of, sorry, going backwards. Here's an example of one of those emailed member announcements. This is reporting back in June after we conducted that poll about prescribers, how they felt about having their information shared with a pharmaceutical company. So in addition to sharing that information with Health Canada, we wanted to share it back with the CAPS community so that they could see what they said and also learn that their important knowledge was being shared with different policy decision makers. All right, so in terms of evaluating the website, under Dr. Dunn's leadership, we adopted an intrinsic case study approach using mixed methods. We gathered data from January 2017, when we launched the website, to October 2019. And we included not only data from the CAPS website, but also went back to our interview data, the interviews that I had conducted with prescribers and pharmacists to see what they reported on, because we did ask questions related to their use of the CAPS website and other supports that they had engaged with. This is a snapshot of the growth of membership of the website. Although this reports on up till December 2020, it's quite well attended. You can see over 1,410 total members on the website, of which over 700 are physicians. I also really want to note here that 86 of our members are midwives. And although midwives, almost all midwives in Canada are not able to provide medical abortion as part of their broad scope of practice, there are some examples in Ontario, and there's broad awareness of the importance of including medical abortion in midwives' scope of practice. In particular, for two reasons. One, to support the sustainment of the profession and include these important reproductive services as part of midwife scope of practice, so that they can really engage into their full scope in midwifery care. And then the second piece is around the appropriateness of midwives in engaging with clients who are seeking abortion services, who already have longstanding relationships with community members, and provide us a relationship-based scope of practice that's appropriate for abortion access. One thing to note, in addition to Ontario, where we have some pilot examples, is as of this past year, in June 2022, midwives provide medical abortion as part of their scope of practice in Quebec. And so we can see some early learnings of what that might mean for other provinces and territories. And here I'd like to point out that as of April 2020, this is when there is a practice guideline released around access to medical abortion using a no-touch or low-touch protocol. We saw a rapid spike in membership during that period as people started to adopt this practice and engage in it more fully in order to support people who were facing health service lockdown conditions during that first season of COVID-19. Our monthly downloads of prescriber resources have been quite impressive. Here I show again the spike in downloads of that practice guideline for COVID-19. Our prescriber resources have been downloaded over 4,000 times. And notably, pharmacist resources were downloaded over 18,000 times total when we collected this data in December 2020. And I think this reflects the incredible outreach conducted by the pharmacist co-leads on this project. They've also published a series of papers and commentaries about the continuing education provided to pharmacists and pharmacy chains, which is such an important contribution to the international literature. We've seen very slow shifts, but positive shifts in access to medical abortion by pharmacy dispensing in the US. And I think the Canadian example of how well that works is such an important and informative piece of evidence. Through the evaluation, we also continued to see that the majority of providers were practicing in primary care settings. Few worked in communities with no prior local abortion services, but even though it was a small proportion, it equated to 30% more communities total in Canada with local abortion access. We also continue to see in different reports that more rural professionals are engaged in comparison to those in urban areas. What was really provided value to people who were members of the website and who were physicians was the resources. So that push communication, emailing about regulatory and policy updates, it created a sense of belonging and community. As one participant noted, they said, "I've got no idea how I'd learn about changing regulations if it weren't on CAPS." Another noted in our interviews that they felt sort of like a feeling that it makes you part of a community with people with common interests. By 12-month follow-up, after initiating the CAPS website and starting our data collection, 78% of CAPS members had implemented MIFI, and this included 65% of those who had no previous abortion experience. And so in summary, this evaluation gave us important evidence on how CAPS supported new providers to implement medical abortion. This has the potential for, when there was reduced access to abortion care during the pandemic, we saw growth in CAPS membership and uptake of clinical practice guidelines. And it shows CAPS, again, not just as being a community of support, but being an important knowledge translation intervention. And I also, from the initial feedback we received about that theme of building community, there's this potential for communities of practice to normalize clinical practices associated with stigma, in particular around sexual and reproductive health care. Moving forward, together with colleagues from CART and the School of Nursing, the community of practice will be updated so that we can extend the reach of medical abortion and sustained practice. And we're also going to be working with partners to generate further interventions that connect with this website that support the public to connect with abortion providers. This includes our work that we have ongoing around development of a patient decision aid that can support people to consider what method of abortion matters most to them and how to access a provider. And we're also working with Action Canada for Sexual Health to understand what are some potential strategies we could use to raise awareness, not just for the public, but for providers, that they can engage in this service. They could use a resource like CAPS to support implementing mifepristone medical abortion. So I'm really excited about these next steps with this area of research. Next, I'm going to turn us to look at a snapshot, or a subsection rather, of the Canadian Abortion Providers Survey. This was a project that was led by Dr. Regina Renner and Dr. Marie-Soleil Wagner from Quebec. Regina Renner is with the UBC Department of Obstetrics and Gynaecology. And they conducted a follow-up of the Canadian Abortion Providers Survey. This was first conducted by Dr. Wendy Norman in 2012. And in it asked questions about stigma and harassment. So at that time in 2012, about 44% of abortion facilities experienced violence or harassment in Canada, mostly in the form of picketing. And what the team was interested in was to understand what happens with stigma and harassment when abortion is diffused into primary care. And so this was a cross-sectional anonymized online survey conducted through 2020. There was a stigma and harassment component to the survey that I'm going to report on, and participants were asked about their abortion practices and experiences for the year 2019. So imagine those conditions prior to COVID-19. And this was 2 years after mifepristone was implemented into care in Canada. One of the components of the stigma and harassment survey was the abortion providers stigma scale. It also included this open-ended question asking about their general comments. And there were 500 respondents in the total survey. I'm going to be reporting on the 354 that started the stigma and harassment sections. You can see here primarily these were physicians. Some also identified themselves as administrators. The majority of them were also family physicians. Starting first with our results on reports of harassment among abortion providers in Canada. Among administrators, 46% reported some harassment and 12% of clinicians. 18% of clinicians indicated they had seriously considered changing the care they provide because of harassment. And 3% of clinicians indicated that the level of harassment they experienced actually made them change the type of abortion care they provide. In some comments, they reported on maybe changing the space in which they practice or even the province. Bubble zones are an important intervention, a type of legislation that can support preventing protesters and picketers from entering the space where providers and clients are engaging in seeking or providing abortion care. About 15% of clinicians and 44% of administrators provided services in clinics that were within a bubble zone. 20% of clinician respondents said they'd be more likely to provide services if there was a bubble zone, and that this would also help hiring and retaining providers. And most administrators thought a bubble zone would impact patient care positively. As one participant described to us in the comments, I currently work in an academic general hospital, so I feel anonymous. If I were to work in a designated clinic where I'd be identifiable as a provider, I would prefer to work in a bubble zone. Turning next to the abortion providers stigma scale. This is a scale that is scored out of 175. Lower scores mean lower perceptions of stigma. So here you can see among all respondents, the mean score was 67.8 with a range of roughly 65 to 77. The results from our sample here, they're slightly lower than that observed in the US. So for instance, recent studies in the US observed a mean score of 76.1 among US providers and 70.9 among providers in the Republic of Ireland. With higher stigma experienced by providers working in hospitals, compared to in general practice, which we hypothesize has to do with what that respondent was talking about before, being in an identifiable setting, or in a setting where they may receive harassment by phone or in person. Also, respondents who had fewer than 5 years of abortion practice experience, including those newly offering mifepristone in primary care, they had the lowest mean score in comparison to peers with more years of experience. And this is consistent with our qualitative data. We had a range of responses, and we're starting to get ready to submit a paper that summarizes those responses. I'm not going to go into the qualitative data in the space of this publication, but I think what I want to share is a key take-home message here. Essentially that in Canada, abortion providers report relatively low perceptions of abortion-related stigma. Those who do experience it express strong concerns, and typically they're in locations where they're identifiable as an abortion provider, and it's difficult to maintain confidentiality. And this in turn is reflected in the data we gathered that participants were hesitant to advertise their services because of a fear of stigma and harassment. And these are perceptions. I want to emphasize that. Actual events of stigma and harassment are relatively low. And so there's opportunity for improvement. And I think this has implications for other areas in sexual and reproductive health where we want to remove the stigma and provide supports to providers who are highly motivated to provide these types of services. So I want to turn briefly, as we close up the session and then make room for some Q&A, I want to turn briefly to highlight 3 current projects that have resulted from this program of research that are addressing stigma more at a patient or population level, and I'll talk about some of the implications for providers. So first, I'm leading a team that's conducting a national qualitative study to understand contraception access among youth in Canada. This is a large qualitative study that's co-led by peer youth researchers. They have recently relabeled it Ask Us, Youth Voices to Improve Contraception Access, which really emphasizes that this is a youth-led study. It's particularly timely in the BC context, where the provincial government has a commitment that's yet to be fulfilled to provide free prescription contraception for all. It'll also help us to understand how better to integrate contraception and abortion services for people wishing to prevent unwanted pregnancies. The second project I want to highlight is funded through a CIHR Early Career Investigator Award that I share with my colleague, Dr. Salima Meherali. We are interested to understand the perspectives of immigrant and newcomer youth as it relates to contraception and abortion care. And I'd like to highlight the work of one emerging leader with this project, one of my master's students, Zeba Khan. For her master's, she's been engaging in integrated knowledge translation with settlement service providers. These providers are often the first point of contact for newcomer families, and they can be a trusted resource when linking with health services in the community. So Zeba is working with Options for Sexual Health, which is BC's Planned Parenthood, and she is seeking to understand opportunities to increase access to sexual and reproductive health care by linking better with settlement service providers. This past year, she conducted a series of priority setting workshops, and this is the graphic recording that summarizes those discussions. I'm really excited that she's about to embark on more qualitative data collection to understand better what people need when seeking sexual and reproductive health care with a focus on contraception. Now, the third study I'd like to highlight is a community-driven project. In this, I'm partnering with Indigenous community partners about accessing family planning services in BC. We already know from existing research and community knowledge that Indigenous clients routinely experience inequitable access, coercion, and stigma when engaging with contraception and abortion services. However, these are limited data, and they illustrate the experiences from the perspectives of Indigenous peoples themselves. We need more data. We need to hear from specific community settings so that solutions can be community driven. So together, I'm working with a team to explore what family planning means to Indigenous communities, what clients' experiences of accessing care is like, and also to explore some novel models of care, including the roles of doulas and midwives in Indigenous-led family planning services. I'm so delighted to co-lead this work with members of the Vancouver Coastal Health Indigenous Health Team and First Nations Health Authority. And this project is overseen by the Matriarchs and Knowledge Keepers Advisory Circle, which is led through the VCH Indigenous Health Team. They have been guiding every step of the research design, and this graphic illustration here summarizes the advisory's vision of their values for engaging in and supporting research. The stories that are with clients and providers of care that are gathered through this project, through one-on-one interviews, they will be conducted by community-based researchers and Indigenous trainees who are trained in culturally safe and trauma-informed research methods. Some of those team members I'd love to shout out here, and some of you are here as part of the audience today. I'm so delighted to work with this talented group and their families and their pups. And this brings me to the end of the talk. Thank you so much for the invitation again and the time to share this work. Please feel free to check out the CART website, which can also connect you with our community of practice.